Good morning. I am Dr. Nermeen Samy Abdel Fattah, Professor of Dermatology and Venereology. My lecture today is about fungal infections of the skin. By the end of this lecture, you should be able to diagnose the different types of fungal infections of the skin, hair, and nails. To know how to confirm your diagnosis of the cutaneous fungal infections, and to be able to treat fungal infection of the skin, hair, and nails. Fungal infections of the skin are usually confined to the stratum corneum, what is called superficial mycosis, but the mycosis may invade other tissues. Regarding superficial mycosis, it may be either dermatophytes or yeast infection. Dermatophytes are multicellular filaments or what is called hyphae, which reproduce by spore formation, while yeast are unicellular organisms that replicate by budding. For clinical classification of dermatophytic infection, if it occurs in the scalp, it is called Tinea capitis. In the bird, Tinea barbae. In the glabrous skin, it is called Tineacorporis or Tinea circinata. When it involves the genitocrural area, it is called Tineacorporis. The foot, it is called Tinea pedis, while involvement of the nail by dermatophytic infection called Onychomycosis. Regarding dermatophytic infection, when it involves the scalp, as I mentioned before, it is called Tinea capitis. There are 4 types of Tinea capitis: scaly ringworm, black dot ringworm, Kirion, and Favis. Regarding the first one, scaly ringworm, it may be caused by what is called Trichophyton violacum or Microsporum canis. It presents as single or multiple scaly patch as shown in the figure, with the hair cut short. Healing occur completely without any scarring. Regarding the second type, what is called black dot ringworm, it is caused by Trichophyton violacum. This condition is similar to scaly ringworm. However, the hair is broken off shortly after it erupts from the scalp and so appears as black dot, and hence the name black dot ringworm. Scaling is mild and healing occurs without any scarring. The third type is called Kirion. It represents a severe inflammatory reaction to the invading fungi, mostly caused by animal origin, Trichophyton verrucosum or Trichophyton mentagrophyte. It appears as single, sometimes multiple, painless swelling of the scalp. The hair is easily detached and the surface of the swelling is studded with few pustules as shown in the figure. The regional lymph nodes are not enlarged and with no affection of the general condition of the patient. It should be differentiated from acute pyogenic abscess, and the incision is completely contraindicated. Kirion heals with a scar, what is leading to scarring alopecia if neglected, and with normal regrowth of hair if treated early. The fourth type is what called Favis. It is caused by Trichophyton chenuli. There is usually a diffuse involvement of the scalp hair, and the affected hair is surrounded by thick yellow adherent crust, what is called sulfur cups or scutula. Slow extension of the lesion may occur to involve the entire scalp. Unlike the other types of fungal infection of the scalp, healing usually occurs by scar formation, and permanent alopecia or cicatricial alopecia is the end result. The next type of dermatophyte infection is what is called Tinea barbae. The lesion is similar to Kirion, but it affects the bird hair, and the angle of the jaw is the commonest site to be affected. The third type was called Tineacorporis or Tinea circinata, which involves the trunk or the limbs. It presents as a severely itchy circinate lesion, where there is central healing and the active raised edge showing minute papule, pustule, and crust. The edge of this lesion is the recommended site for scraping to confirm the diagnosis. The differential diagnosis of Tineacorporis or Tinea circinata is circinate impetigo or Petraeus rosea. Here we can see central clearing, raised edge with sharp marginated active edge. The fourth type is what's called Tineacorporis. It is mainly caused by Epidermophyton fullocosum or Trichophyton rubrum. It is more common in adult male. It is characterized by a well-defined erythematous patch with raised active edge affecting the upper medial side of the thigh and may extend to involve the buttocks and pubic area. The differential diagnosis of affection of the intertriginous lesion is what is called erythrasma, candidiasis, intertrigo, flexural psoriasis, or seborrheic dermatitis. The fifth type, it was called Tinea pedis, or athlete foot. It is common in adult, especially young men, and is more often predisposed to by communal washing, swimming baths, occlusive footwear, and hot weather. There are three clinical variants. The most common was what is called macerated toe web or chronic interdigital Tinea pedis, which is the most common type, characterized by itchy interdigital maceration affecting mainly the fourth and fifth toe web space. The second type, it is what's called squamous hyperkeratotic or chronic scaly type of Tinea pedis. And the third type is acute vesiculobullous. The last or the latter two conditions are less common than macerated toe web. Macerated web space can be a manifestation of one or more of the following, either dermatophyte infection, candidal infection, or gram-negative bacterial infections. Fungal infection of the nail by dermatophyte is called onychomycosis. It could be also caused by candida or mold. The infection usually starts laterally or at the free margin of the nail and is facilitated by trauma, diabetes, or moisture. Affected nail appears with loss of luster, brittle, friable, with evidence of subangular hyperkeratosis as shown in the figures. The next type of fungal infection, it is what's called Petraeus versicolor. It is a very common, mild chronic infection of the skin affecting adults and rarely children, caused by Malassezia yeast. In most conditions, it represents a shift in the relationship between the human and his resident yeast flora, what is called yeast mycelial shift. The factors contributing to this change are mainly excessive sweating, humidity, and oily skin. Clinically, it is characterized by well-defined hyper and hypopigmented macules and patches covered by cigarette paper-like scales. It affects mainly the trunk and the neck, less commonly the face, as shown in the figures. To confirm the diagnosis, we use what is called Wood's light, which gives a characteristic golden yellow fluorescence. Recurrence rate is high even after treatment. Cutaneous candidiasis is mainly caused by the yeast Candida albicans, and the predisposing factor for such a condition may be diabetes, obesity, moisture, immunocompromised individual, the prolonged intake of broad-spectrum antibiotic, and old age. It may be present by either oral thrush or oral candidiasis, characterized by white curd-like patches, what is called pseudomembrane, which may occur on the tongue and or buccal mucosa. The patches may be scrubbed, leaving erythematous base. Angular stomatitis is commonly associated. The second type is candidal intertrigo, which may affect the groin, axilla, or submammary areas. The lesion is well defined, moist, and erythematous, and the edge is festooned with small satellite lesion in the form of papule and pustule seen outside the edge, as seen in the second figure. Napkin candidiasis or candidal intertrigo of the napkin area can occur in infant and should be differentiated from other causes of napkin dermatitis. The last type, which is rare, is what's called chronic mucocutaneous candidiasis. It is a rare condition which is due to a state of immune deficiency against candidal organism. It is characterized by chronic paronychia, oral candidiasis, hyperkeratotic lesion on the hand and feet with subangular hyperkeratosis. The second objective of the lecture is how to confirm our diagnosis. It can be either done by examination under Wood's light microscopic examination of the hair and scale, culture on saburo agar medium, or biopsy if indicated. Regarding the first one, which is examination under Wood's light, it is used mainly for Tinea capitis, especially for screening during outbreak, such as school children. The hair infected with Microsporum canis and Microsporum oduni show green fluorescence, but trichophyton violation does not give any fluorescence. Regarding microscopic examination of the hairs and scales, we do scraping from the active edge of the lesion. The most important is to take the scraping from the active edge that will be collected on a glass slide and applying a drop of KOH 10 to 20%, followed by gentle warming. Avoid excessive heat and boiling. Then the specimen is then examined under light microscope. In positive case, it may show hyphae and spores. Finally, we have to know how to treat a case of fungal infection of the skin, hair, or nail. The first is we have to avoid any predisposing factor, as humid and sweaty condition, including occlusive footwear, that have to be minimized. Minor fungal infection respond well to topical treatment, but widespread involvement or affection of the nail or scalp requires systemic therapy, even if single lesion. Regarding topical therapy, we can use either tincture iodine 2 to 5%, Whitfield ointment, broad-spectrum topical antifungal, such as clotrimazole or ketoconazole, and topical aqueous solution of sodium hyposulfite 20 to 25% in case of Petraeus versicolor. Regarding the systemic treatment, we can use graziofulvine, terbinafine, or broad-spectrum antifungal systemic treatment. Graziofulvine is an oral fungostatic agent, readily absorbed from the gastrointestinal tract. It has to be taken after fatty meal. The dose is 12.5 mg per kilogram per day, with maximum allowed dose 6 tablets per day, and the tablet contain 125 mg. The duration of treatment is 6 to 8 weeks in Tinea capitis and is usually extended to up to 8 weeks in Favis. In Tineacorporis and Tinea circinata, the duration of treatment is about 2 to 4 weeks, while it is 6 months in onychomycosis of the fingernails and up to 12 months in case of toenail onychomycosis. This drug is not effective in case of candidiasis or Petraeus versicolor. The second systemic antifungal, terbinafine, which is active against dermatophyte only. Then broad-spectrum antifungal as itraconazole and fluconazole, which can be used in severe and extensive cases. In case of candidal infection, we can use topical antifungal as imidazole or systemic treatment in case of severe, extensive, and resistant cases in the form of broad-spectrum antifungal agent as itraconazole, fluconazole. Graziofulvine is not effective in case of cutaneous candidiasis. Please be ready with your question in the next face-to-face session. Thank you.